Hey guys! So for my mini teach, I chose to talk about pusher syndrome. Before this week, I personally had never heard of pusher syndrome before, so it was very interesting to learn about. With pusher syndrome, it really kind of gets me because it changes how we would approach treating a patient with pusher syndrome compared to a patient who just had a CVA. So it is taking me a little bit to kind of wrap my head around that, which is one of the reasons why I chose this topic, so I can get a better understanding of it myself. So with pusher syndrome, what happens is a patient who has had a stroke will lean in towards their affected side. So for example, if I had a left CVA, then my right side's affected, I will be leaning towards the right and vice versa. So it is ultimately pretty rare. It occurs in about 5 to 10% of patients post-stroke, and it can also be seen in patients who haven't had a stroke and who have had brain injury or cancer. With pusher syndrome, it will affect several areas of that patient's life and impacts essential activities such as transfers, standing, and gait. And this will put them at increased risk for falling because they are off balance. With pusher syndrome, it's challenging because the patient is often unaware that it's occurring. In their mind's eye, they are in an upright vertical position when in reality they're leaning towards the side. And with that, they will resist passive correction. And so that means is if I had pusher syndrome and I was leaning towards my side and a therapist were to push into my affected side and try to get me upright, I will be resisting it because in my mind, I'm already upright, you're pushing me over. So it is a more challenging approach, and you will have to kind of work around a few things in order to treat patients with this impairment. So with pusher syndrome, is usually associated with posterior thalamus damage, but it can also be seen in patients with injuries to the insula or post-central gyrus, which makes sense because these areas are important for regulating upright posture. With pusher syndrome, it is more common in a right hemisphere stroke or injury, but it can occur with left hemisphere stroke or injury. Some of the things that you will see with pusher syndrome is the patient will tend to lean approximately 20 degrees towards their affected side, and they will have deficits in body orientation perception. Again, in their mind, they're upright, they're perfectly fine, but in reality, they're leaning about 20 degrees towards their side. And they feel unbalanced when they are truly upright and truly in line with midline, which makes them a lot more challenging to treat in convincing them like you are not upright and trying to show them what's wrong and how to correct it. They primarily have visual or visual perception problems, impaired proprioception, and motor impairments, but it's not found to occur with vestibular dysfunction. With pusher syndrome, it can co-occur with other impairments seen with stroke. For example, if it's a right hemisphere stroke, they may also be experiencing left neglect on top of pusher syndrome. If the left hemisphere is damaged, they may also have aphasia on top of pusher syndrome. With pusher syndrome, it can resolve within about 6 months post-stroke. They're able to return to almost normal function because of neuroplasticity, which is why it's so essential for them to begin their rehabilitation as soon as possible. Because if they're not getting back to that midline position, they will just continually be leaning towards their affected side. The goal is to maintain a vertical body position while performing other activities, which is the goal in rehab. And with rehab in pushers, it is a little different approach than a patient who's just had a CVA. With pusher syndrome, visual cues are essential. Again, the patient doesn't realize they're leaning towards the side, so they need to be shown visually that they are out of midline. So the most common way to deal with that is to use a mirror when treating the patient so they can see that they are, in fact, leaning to the side. And you can also take a piece of tape, place it vertically on the mirror to give them a physical line that they can see. So if they are leaning to the side, they're able to readjust. With a therapist, the positioning is different opposed to a stroke patient who's had hemiparesis. So usually the therapist will be on the weak side to be able to support that side. But with pusher syndrome, you want to be on the opposite side. You want to be on their stronger side. That's because if they're leaning to the side already and the therapist is there, they'll lean more into them. And anytime there is stimulation on this side, they will go towards it. So the therapist wants to be on that strong side so the patient has a solid object, a place where they can lean into. Another thing I saw is you can have the patient take their unaffected hand and place it palm up in their lap so they're not continuing to push on it towards their affected side. And when they get to the point where they're ambulating and getting up, because they're a stroke patient, they'll be using a hemi walker. And usually you'll want the hemi walker to be measured appropriately to the patient. But in the case of a patient with pusher syndrome, what you want to do is take the hemi walker, put it 2 notches lower, so the hemi walker is shorter. Because if the hemi walker was measured appropriately, the patient will be leaning towards their affected side still. If it's lower, that forces the patient to lean towards their stronger side a little bit more and kind of regulate them into a more upright position. With pusher syndrome patients, they want to be treated in an earth vertical position, meaning you don't want them horizontal, you want them sitting, standing, or walking so they can continue working on being realigned with midline. I've also seen in my research that you can use a TENS unit to the contralesional side of the neck when performing balance activities. And they found that that was helpful in patients with pusher syndrome. I didn't see too much more on it, so I don't know how effective or if it's commonly used, but it is used. And even though pusher syndrome is fairly rare, because of all the different modifications you have to make towards treating a patient with pusher syndrome versus a patient with a CVA, it is important to really grasp it so you can give them the appropriate rehabilitation and get them back into midline to ultimately keep them safe, to reduce their risk for falls, because if you are already in this position, it is much easier to lose your balance and fall. And because they are a stroke patient, they're already at a high risk of falls anyway. So knowing how to approach treatment with pusher syndrome is very essential. All right, that's all. Have a good one.